Welcome to the Solid Tumor Virtual Seminar presented by the Massachusetts Medical Society at OMED Live. My name is Dr. Bruce Johnson, and you're tuned in to a live session called Inhibition of Molecular Signaling Pathways, Resistance Mechanism, and the Durability of Response to Pathway Inhibitors in Non-Small Cell Lung Cancer with Dr. Pasi. Before we get started, I'd like to remind our audience I'll be taking questions in real time throughout this presentation. You can send me your questions anytime during the program through the box in the lower left-hand side of your screen. Dr. Janne is an associate professor of medicine at Harvard Medical School. He received his MD and PhD from the University of Pennsylvania in 1996. Dr. Janne.
Thank you, Dr. Johnson. I'm going to talk in follow-up to Dr. Costa's presentation today and talk about really the emerging problem of what happens when, despite the incredible successes of the targeted therapies that you heard about, when patients develop resistance to these agents. This first slide has my disclosures on it. So as you heard from Dr. Costa, our general view of lung cancer has changed dramatically over the last decade. And really, we don't think of lung adenocarcinoma today as just one disease, but a disease that's composed of several different subsets. Most notably, the EGFR mutant subset and the ALK-rearranged subset, shown on the bottom right, are ones where we have effective targeted therapies today. And I'll talk about what happens when those therapies stop working. The other subsets highlighted in the pieces of the pie are ones where we have therapies that are actively being explored. For example, you heard about ROS1 rearrangements from Dr. Costa, and there are others out there, and we hope the same kinds of paradigms will hold true as has so far been the case for EGFR and for ALK. Now, just to highlight some of the important discoveries and to recap some of the findings from Dr. Costa. You see here in the large sets of clinical trials that have evaluated looking at EGFR kinase inhibitors compared to chemotherapy in patients with EGFR mutant lung cancer, that in every situation highlighted in red in the chart, an EGFR inhibitor is associated with a greater radiographic response rate compared to chemotherapy. You can see on the right-hand side the median progression-free survival in patients that are treated with EGFR inhibitors who have an EGFR mutation. And for reference, this with chemotherapy would be about 4 to 5 months. So you can see that it's an improvement, but I think at the same time you see and appreciate the fact that patients still develop resistance to these agents. The therapeutic benefits do not last forever. And again, that is the challenge and opportunity to figure out what to do when these agents stop working. Similarly, with crizotinib, the randomized phase 3 clinical trial that was recently published in the New England Journal of Medicine in patients that had previously received therapy with first-line chemotherapy who had a documented ALK rearrangement, in that subset of individuals randomized to crizotinib or pemetrexed, with the primary endpoint being progression-free survival in this randomized phase 3 clinical trial. And what you can again see from here is that the curves do separate. Crizotinib is better, as you heard from Dr. Costa. It's associated with a longer progression-free survival, a better improvement in the quality of life. But you see that the curves are not flat, meaning that the curve in blue, which represents crizotinib, also still comes down, meaning that patients ultimately develop resistance to this class of agents. It's better than chemotherapy, but unfortunately, we're not yet at the point where we're curing individuals with these targeted therapies. However, as you'll see from the presentation, I think this is our foot in the door. This is our opportunity to build upon this experience of an EGFR inhibitor, of an ALK inhibitor, and understand why resistance happens, how we can develop better therapies, or how we can develop better therapeutic combinations to ultimately separate these curves much further apart and to reach the ultimate goal of, in fact, curing patients with advanced non-small cell lung cancer. Now, there are really 3 clinical options that are discussed typically when we reach the point where we think that the targeted therapy has stopped working. Now, we define progressive disease based on radiographic criteria called the RECIST criteria. And here, the criteria, the definition of progression is that you take the smallest lesion, so after a patient has responded to the therapy, and calculate the longest diameter, and if that increases by greater than 20%, then it's defined as progression. So in practical terms, if you had a 10-centimeter tumor, just one tumor, and it shrunk to 1 centimeter in a patient felt great, it was a great response, and if that tumor grows to 1.21 centimeters, that would count as progressive disease. Now, many times and often, patients are asymptomatic, the disease growth is slow, and the question comes, even though that is the technical definition of progression, is that a time when we should stop that therapy, or is the patient still benefiting from that type of treatment? A second practical question is, do you switch to chemotherapy? Do you add chemotherapy to an EGFR inhibitor or an ALK inhibitor? What's the right approach? And I'll discuss some of the data for that as well. And finally, we can use our molecular and biologic understanding of figuring out what is the resistance mechanism, how is the cancer developing resistance against this targeted agent, and can we use that information to guide the next therapy, to figure out new therapies, or figure out new combinations of treatments. So let me show you some basic diagrams in biology of cancers that are like the EGFR mutant cancers or the ALK rearranged cancers, what we call the oncogene-addicted cancers. And this, again, dovetails well with what Dr. Costa talked about from the clinical side. So we generally think that cancers have a mixed population. There is, in general, a sensitive population, but the resistance that happens in cancers probably is there before the therapy has ever even been initiated, represented here in this red cell amongst the blue sea of sensitive cells. Patient gets a targeted therapy, such as an EGFR inhibitor, the tumor shrinks. You're now shrinking the blue cells, the red cell still remains, the tumor is now smaller, it has now responded, we've now seen a clinical response. You continue the treatment, and over time because the red cells are resistant, they will now start to populate and grow, and the cancer begins to grow and now develops resistance, again, which we define radiographically. When you then have a decision to withdraw the therapy, and again, here's where some of the biology comes into play, what can then happen at that point is that both the red cells that are resistant to the therapy and the blue cells that were once under control of the treatment now have an opportunity to both grow. And this model highlights or depicts what's called a flare phenomenon, meaning that sometimes when we stop the therapy in patients, the tumors all of a sudden regrow and the patients develop symptoms from the regrowth of their cancer. And again, if you reinitiate therapy, sometimes that response, the tumor now once again shrinks. So what this phenomenon, this flare phenomenon is something that has been observed for both EGFR mutant lung cancer and for ALK rearranged lung cancer, really first demonstrated and published on by a group at Memorial Sloan Kettering. And what they noticed that in about 23% of patients, so 14 of 61 patients here, this happened when individuals where their therapy was stopped, the kinase inhibitor was stopped.